Hello, my name is Tanya Sanchez, and I will be presenting a case study about a patient that was diagnosed with hemorrhoids. So we had a 53-year-old female with a chief complaint of having rectal pain and discomfort for 2 weeks, and she stated that she believed she had a hemorrhoid. The 53-year-old female presented to the office with rectal discomfort and itching/pain for 2 weeks. She wasn't sure she had a hemorrhoid, but she felt a mass to the rectal area. She was applying preparation H, but it was not helping. She didn't have pain during the time of the visit, but she states that when she does have pain, the pain is about a 4 out of 10, and she describes it as a dull pressure-like pain that's worse when she sits. She's also using cooling pad to help her with the discomfort. Review of systems, generalized systems. She does not have fever, chills, fatigue, or unintentional weight loss. Cardiovascular systems is unremarkable, no complaints. Respiratory systems also denies cough, wheezing, or shortness of breath. GI systems, she did have a complaint of the rectal mass, but she denied abdominal pain, nausea, vomiting, diarrhea. She does have a history of occasional constipation. She denied blood in the stool and also complaining of the rectal itching. GU, she had no complaints for the GU systems, and for the skin, again, she was just complaining of the itchiness to the rectal area. Medical history, she has a history of hypertension, hyperlipidemia, depression, overactive bladder, obstructive sleep apnea, which she does use a CPAP. She does have a history of severe COVID with intubation and trach. Surgical history included a liposuction in 2022. Social history is she does not smoke, drink, or use drugs. She works as a hospital kitchen staff worker. She does not exercise. She states that her diet is pretty much healthy. She eats about 2 to 3 servings of fruits and veggies daily and drinks about 8 glasses of water a day. Family history, her mother is deceased at the age of 75, but she had a history of hypertension, diabetes, and breast cancer. And her father is currently alive at 80 years old and history of diabetes. She also has no known allergies. Medication she takes at home include aspirin 81 milligrams daily, hydrochlorothiazide 12.5 daily, losartan 100 milligrams daily, atorvastatin daily, albuterol pump, metformin daily, and fluticasone inhaler. Physical examination, vitals are pretty much unremarkable. Temp is 97.9, pulse 71, blood pressure is 117/76, respiration is 20, pulse ox is 98% on room air. Cardiovascular physical exam was unremarkable. Her respiratory physical exam was also unremarkable. Her abdominal physical exam, her abdomen was soft, non-tender, non-distended. She had bowel sounds present in all 4 quadrants, and she did have a reducible hemorrhoid to the anal area. Her skin, generalized skin, warm, dry, and intact, no paler or generalized rash noted. She also did not have any erythema or induration to the anal or rectal area. Based off of our physical exam and our H&P, this patient's working diagnosis is hemorrhoids. Once we examined the hemorrhoid, we did give it a grade 3 based on our physical exam. Our differential diagnosis that we considered for this patient, there were 3. So the first one was anal fissure. We considered it because anal fissures can mimic hemorrhoids based on the rectal, because they can cause rectal discomfort, they can cause bleeding, and sometimes they have a skin tag present around the anal opening, which some can confuse for a hemorrhoid. She did not have bleeding, and she also did not have the distinguishing features of an anal fissure, which would include patients would complain of sharp burning pain during and after defecation, which can persist for hours. They also do complain of that mass, or skin tag, which upon examination we determined is not a hemorrhoid. Also, compared to hemorrhoids are usually painless and also have a dull pressure like ache or pain and itching, whereas anal fissures do not. So based off of these distinguishing characteristics, we did not go with, or this patient was not diagnosed with an anal fissure. The second differential diagnosis is a perianal abscess. So during the early stages of a perianal abscess, it could be confused or thought to be a hemorrhoid. because of the discomfort and itching, which is usually present with the early stages of a perianal abscess. However, the later stages of perianal abscess distinguish it from a hemorrhoid because the patient has a lot of pain, not a dull ache. They can have an induration and drainage and tenderness on palpation. Treatment plan for a perianal abscess also differs because the patient usually requires an IND, whereas a hemorrhoid can be treated with other conservative measures. So based off of these characteristics, the patient was also ruled out to have not to have a perianal abscess. And finally, the last differential diagnosis that we did consider is a perianal dermatitis, which can be idiopathic or can be caused by an irritant. So it's one of the most common causes for perianal pruritus. So upon physical examination, if the patient does have, or patients that do present with perianal dermatitis, their skin is seen to contain or to be erythematous, macerated, or lymphified. It's usually caused by excessive wiping, fecal soiling, moisture, or contact with some type of irritant. So again, this patient did not meet the criteria for this diagnosis, so this diagnosis of perianal dermatitis was excluded. The clinical guidelines that we followed for the diagnosis or for the treatment for this patient was based off of the guidelines created by the American Society of Colon and Rectal Surgeons, and also the clinical guidelines created by the American College of Gastroenterology. So based off the guidelines that these associations suggest or present are usually patients have to have a thorough history, which should evaluate the frequency and severity of symptoms. They should also have differential diagnosis excluded. They should have a physical examination to evaluate internal and external hemorrhoids. They also may need a DRE. Next, if patients are found to have hemorrhoids should be graded between grade 1 or 4. If the patient does need further evaluation or the source of bleeding is not found, if patients do complain of bleeding and no hemorrhoids is found, they may require colonoscopy. And also the guidelines recommend starting the patients on conservative treatments which include improving bowel habits, dietary changes, and or topical treatments. If the conservative treatments are unsuccessful, then the patient may need further surgical interventions. So the physical examination findings that present with a patient that had hemorrhoids is a soft tissue protrusion around the anal area that's irregularly shaped. They may also have a prolapsed internal hemorrhoid that may appear fleshy, shiny, or pink, and with mucosal tissue that protrudes into the anal canal. Some risk factors that the ACG states: patients that have history of constipation, chronic straining, a low dietary fiber, or long periods of sitting, they're at risk for hemorrhoids. The pathophysiology of hemorrhoids are that they are caused by a loss of connective tissue support. This loss of support weakens the rectal tissue and then makes the patient susceptible to prolapse due to the trauma from straining and or hard stools. So usually this is what is the cause of hemorrhoids. So the grading systems for hemorrhoids, again, they go from grade 1 through 4. So internal hemorrhoids are graded first. Grade 1 is a prolapse into the anal canal with no external protrusion. Then there could be a grade 2, which is a prolapse beyond the anus with spontaneous reduction. So if the patient bears down, or you can see the hemorrhoid, but if they're not bearing down, you do not see anything. The grade 3 are prolapse, which require manual reduction. And then the last is a grade 4, which is a hemorrhoid that is not reducible. So steps in the treatment for hemorrhoid disease. So guidelines recommend the first line treatments would be conservative treatment. So that would include increasing fiber intake, increasing fluid intake. Again, the 6 to 8 glasses of water a day. Fiber intake would be about 20 to 30 grams daily. Behavioral counseling, so not sitting on the toilet for a long time. Topical hydrocortisone. You can use Preparation H, which is over the counter, or Preparation H 1%, or Anusol HC, which is usually prescribed, or a phlebotomic. The second line treatment for hemorrhoids grade 1 through 3 would include rubber band ligation, sclerotherapy, or infrared coagulation. And then finally, the third line treatment would be a surgical treatment, which would be excisional hemorrhoidectomy, Doppler guided hemorrhoid artery ligation, or a staple hemorrhoidpexy. So this is a nice visual algorithm created by the ASCRS or the ACG to help clinicians with a stepwise approach for treatment for patients with hemorrhoids. Again, it talks about the history and physical, a good history and physical, a good physical examination, reviews whether or what would require colonoscopy if there's concern for colorectal pathology. Again, it goes through the grading systems for the different grades of hemorrhoids, so they can be a grade 1 through 4, what the initial therapy is, and also what to do if there is no or insufficient response based on the initial therapy. So treatment plan for my patient, we did a non-pharmacological and pharmacological treatment plan. So the non-pharmacological treatment plan for this patient would be to increase her dietary intake, again, for 20 to 30 grams per day of fiber every day. Fluid intake should be 6 to 8 glasses of water daily. She should avoid straining and sitting on the toilet for a long period of time. And we also did a surgical referral based on her hemorrhoid being a grade 3. So pharmacological treatment for this patient wasn't, we changed the preparation H to Anusol HC, which is a suppository that she could use twice a day in the morning and the evening. So the reason that Anusol was a better treatment option for this patient was because preparation H was not effective, and preparation H possibly was not effective based off of the ingredients. So preparation H contains phenylephrine, which is a vasoconstrictor, and it has other barrier ingredients. It can have cocoa butter, starch, or zinc oxide, which can relieve symptoms temporarily. But the phenylephrine is not an anti-inflammatory. So Anusol, in contrast, contains hydrocortisone, which has a direct anti-inflammatory, antipyretic, and vasoconstrictive effect, which is great for this patient's hemorrhoids. And based off of the ingredients, we decided to change the medication from preparation H and prescribe her Anusol to see if that would help relieve the patient's symptoms. So step-by-step pathways for this patient. Where did she fall exactly? So again, she's still in the initial conservative treatment, but we kind of are in the process of escalating her treatment to surgical evaluation. She did undergo a thorough interview and examination, and we are starting the initial first-line treatments. She did drink water. She probably could increase her dietary intake a little bit more. And she was already starting a topical treatment plan, but it wasn't helping. So we did change the topical medication. And we decided to include a surgical consult to see if she needed further intervention because her hemorrhoid is now a grade 3. So this is the step that she falls into the guideline categories. So based on the guidelines, was the treatment appropriate? I would say yes, because we did follow the guidelines. She was educated on the pharmacological and non-pharmacological treatment plans. She was prescribed a different topical treatment, and we also included a referral to a surgeon to help her with her hemorrhoids because they were a grade 3. So some red flags that we need to look into when a patient presents with a hemorrhoid. So red flags fall into 2 categories. There's either red flags that can suggest another diagnosis that is not a hemorrhoid, or it's a patient that does have a hemorrhoid, but they developed a complication of the hemorrhoid or to the hemorrhoid. So symptoms that we can consider or that we can look at that may lead the patient to or may lead the clinician to believe that there's an alternative diagnosis would include symptoms of bleeding independent of bowel habits or bowel movements, an unexplained weight loss or fatigue, iron deficiency anemia, abdominal pain or distension, bleeding despite successful hemorrhoid treatment, and any family history of colorectal cancer, irritable bowel syndromes, or other hereditary colorectal syndromes. So these symptoms, especially the rectal bleeding, they're usually missed or they can be missed on young patients. And We need to consider these symptoms, especially the bleeding, because young patients are often missing the diagnosis of colorectal cancer because the bleeding is associated with hemorrhoids as opposed to cancer because they are young. So we can't miss the opportunity to potentially diagnose a patient with colorectal cancer just because of their age. So it's something that we need to consider as clinicians. Always consider the likelihood of colorectal cancer, regardless of age, with a patient that presents with rectal bleeding. Finally, if the patient has any hemorrhoids and they evaluate or they devolve or they evolve into a complication, then we need to consider these potential complications that are associated with hemorrhoids. So strangulated hemorrhoids are possible. They're non-reducible prolapse or engorged hemorrhoids that have vascular compromise. They're very large, engorged, dusky, and or necrotic, and they usually have these patients usually complain of severe pain, and sometimes they require emergency surgery. The second hemorrhoid complication could be a massive hemorrhoid bleed caused by hemodynamic which can cause hemodynamic instability and may require prompt intervention. So these patients may have a massive bleed from the rectum and be tachycardic, hypotensive, and they need prompt intervention. And finally, a severe unexplained rectal/anal pain that may require examination under anesthesia because it can be something that needs further investigation. So patients with severe unexplained rectal pain can have sphincter abscesses or cancers, which need to be evaluated thoroughly, which is why an exam is done under anesthesia. Okay, so that concludes my presentation on a patient that presented to our office with a hemorrhoid. Thank you.